Hello and welcome everyone to the European Testing webinar. Thank you for taking the time to join us today. My name is Cecilia Bumkahama and I'm a consultant at CHIP and I am the interim project coordinator for European Testing Week. Our webinar series focuses on challenges and opportunities for testing during the COVID-19 pandemic throughout the WHO European region. The specific aim of this webinar is to present case examples of HIV self-testing projects, to discuss the lessons learned and to explore how self-testing can be offered to expand access to testing. I'm happy to welcome Tamar Zurashvili from the Georgian Harm Reduction Network. She is an MD, MPH, and a public health specialist who has been working on various international projects in the fields of HIV/AIDS and TB. Currently, she serves as the manager of a global fund regional project called Sustainability of Services for Key Populations in Eastern Europe and Central Asia at the Georgian Harm Reduction Network. She was the principal investigator of the HIV self-test study that she's going to present for this webinar. I'm also happy to welcome Momchil Baev from Single Step Foundation in Bulgaria. Momchil is a sexual health and HIV program manager who's devoted himself to vulnerable communities, patient rights and advocacy initiatives related to policy changes, access to healthcare and treatment of HIV. He is also a member of the International AIDS Society. I'll just give you some housekeeping reminders before we get started. Please note that as an attendee, you will not have speaker permission, but you are welcome to submit your questions for presenters during the webinar. After the two presentations, there'll be time for questions and answers, so please feel free to enter your questions in the Q&A section on your screen, and then I'll read them out loud and they'll be answered after the presentations. You also have the option of posting your questions anonymously should you wish to do that. Additionally, this webinar is being recorded and will be posted online, so if you can't stay for the entire webinar, you will be able to access the video later on through our YouTube channel and advertised on our web page and Facebook. And everyone who's registered for this webinar will receive a link to the video. Lastly, at the conclusion of the webinar, we kindly ask you to complete a very short evaluation survey to provide us with feedback. The webinar survey will be sent to you to the email which you provided when you registered for this registration. And now for our first presenter, I would like to welcome Tamar Zurashvili.
Thank you, Cecil, for the introduction. I'm gonna share. Here we go. So I will be presenting this study, which was conducted under the, as Cecil mentioned, 3-year multi-country project, Sustainability of Services for Key Populations in Eastern Europe and Central Asia. The project is funded by the Global Fund and is coordinated by the Alliance for Public Health. It covers 14 countries, including Georgia, and in Georgia, the project is being implemented by the Georgian Harm Reduction Network. Just a bit information about the HIV epidemics in Georgia. Georgia remains to be a low HIV prevalence country among general population, but there is still risk of expanding epidemic due to the rising cases of HIV among key populations, especially MSM and PWID, and female partners of these groups might serve as bridge population to general population. Thus, is very important for the HIV response in the country. The HIV transmission over the last few years have been mostly through sexual contacts, while at the beginning of the epidemic, the main transmission route was through drug use. According to the latest BSS studies, the prevalence among MSM is 21.5% and 2.3% among PWID. If we look at the fast-track targets, you see that Georgia has made significant progress in the second and third 19s with 87% of diagnosed patients on RT and 91% with viral suppression, but we still have a gap in the first 19 with almost 36% of estimated PLHIV who are unaware of their HIV status. The testing, HIV testing in Georgia is provided under the state and global fund programs for the groups of population listed on this slide. I would like to mention that HIV self-testing is only available for MSM population under the Global Fund pilot project. This is an online platform for this population. They can order the self-tests online, and Global Courier delivers this test to the beneficiaries. Now we are actually planning to expand this project and include PWID and female sex workers as well. The overall aim of the study was to determine the acceptability of HIV self-testing. We used two types of self-test kits, oral fluid and blood-based test kits. As I already mentioned, it covered two key populations, MSM and PWID. And we had some specific objectives to assess the ability of these target groups, how they understand the instructions for use, what are the reasons for testing, what are the factors associated with the HIV self-test use, as well as evaluate the linkage of care among those who tested positive, and additionally qualitatively explore pros and cons of HIV testing practice and acceptability. We used a mixed method study, so we used a combination of quantitative and qualitative components. For the quantitative components, the study involved distribution of these self-test kits, and 2 weeks later they were approached for a small follow-up survey to assess acceptability and linkage to care. And then we used the qualitative components where the participants of both stages of the quantitative component were interviewed in depth. So I want to stop here. The population groups were MSM and PWD, and the study was conducted in Tbilisi, the capital of Georgia, as well as in different regions of the country where the service sites delivering services for this key population are operational. Little bit about data collection. So study participants were recruited by the social outreach workers of these organizations delivering services to key populations, and they distributed the test kits during outreach sessions and during also facility-based visits. And this distribution was interchangeably. So one day they distributed oral tests, and the other day the blood tests. Participants were given supporting materials together with the self-test kits. The materials included the IFUs, the pre- and post-counseling brochures, a list of service centers where they could apply for additional services, as well as the helpline number. This helpline number was specifically set up for this study. And participants could call if they had need of any additional information. So the data were collected through 2 sets of questionnaires. One was the baseline questionnaire, which was completed during the delivery of the test, and another questionnaire was completed through the phone call after they have conducted this testing. One thing I would mention here, as I told, the data were collected from February to June 2020, and actually it was February 27 when the first COVID case was reported in Georgia, And this had some implication on our study as well, because government of Georgia started employing some measures of distancing, including by the end of March, we had state of emergency and lockdown. So we had to modify some measures. We developed a special manual for these centers, how to operate during COVID, including all the safety measures. Also, the social workers and all the employees were working in shifts for the 2-week periods. In addition, within the SoS project, we procured 1 month's stock of personal protective equipment, and those were delivered to the field workers. We also used reaching these key populations through different social networks, phone and etc. They were offered, the social workers sought consent from them, and then test kits were delivered at their homes. So we managed to complete the data collection in this really hard period for the country. So as I mentioned, between February and June 2020, we distributed 805 HIV self-test kits. All participants who received these test kits completed the baseline questionnaire. For the follow-up questionnaire, we had quite a high response rate. 97.5 participants agreed to participate. Just 1.6 refused participation, and majority did not state any reason, or they told that they did not want to disclose their status, and 0.5% were lost to follow-up, so social workers were not able to contact them. On this slide, I would like to emphasize that risky behaviors such as injecting paraphernalia sharing, inconsistent condom use, combined with the number of multiple sex partners, is quite common among these target groups. As for the HIV testing history, you can see that the regular testing practice is quite low, and especially among PWID. And one important thing, that 23.5% of the entire sample were first-time testers. So they tested for the first time with this provided HIV self-test. Some of the characteristics related to the self-testing, which I would like to underline, is that majority of participants were alone during the testing, especially for the MSM group, and the use of pre- and post-counseling information was quite high among both populations, and especially among PWID. And all of them indicated, majority, that this information was useful. Generally, the acceptance rate was very high among both groups, slightly higher among PWID. Participants found the instructions easy to follow, and the tests were easy and convenient for them to use. And 89.2% of MSM and 90.4% of PWID stated that they would use this test again in the future. Although the primary aim of our study was not to compare these two types of test kits, oral fluid test kits scored a bit higher compared to the blood tests in terms of acceptability. Test results. So among the 785 participants who agreed to participate in the follow-up survey, 91.6% indicated that their results were negative. 2.9% 4.9% of MSM and 1.5% of PWID were positive. 3.5% of participants refused to disclose their status, and 1.8% stated that they didn't know the results, and majority did not provide any reason for this answer. I would also like to emphasize about the linkage to care. So 48% said that they took confirmatory tests. 20 additional percent stated that they plan to take in the nearest future, and only 8% of participants who tested positive stated that they don't plan to take confirmatory tests, and one stated that it was due to fear and another due to distrust for the HIV self-test. So just to summarize the main finding, the study results demonstrated the high acceptability of HIV self-test use among our key populations. It is well evident that HIV self-test is considered as a facilitator for reaching the first-time testers, and our study results also say the same. So we had 23.5% first-time testers, and this percent was higher even among PWID. Due to stigma, it is preferred that self-testing is convenient and ensures confidentiality, and our results also support this statement. 77.7% of respondents used the kits at home. Half of them were alone, suggesting that those MSM and PWID who are hesitant to go to the facility for testing might be the ideal candidates for testing and using this self-test, especially in the COVID situation where countries are experiencing certain restrictions regarding travel, transportation, and so on. As I already mentioned, we did not aim to compare the two types of test kits, but mostly those who use the blood-based test kits stated one of the disadvantages they prick while using the blood-based tests. Supporting materials are very important, and our study also suggests that majority uses this information, and they find this information useful. Also, while considering the wider implementation of this self-testing, we should carefully think about the linkage to care services, so that those who test positive does not stay without HIV services, and it is necessary to introduce different models of dissemination, because in our sample, for example, majority expressed the desire to get the test in the same prevention site, but there were also answered that some would buy in the pharmacy, some would order online, and etc. So different models will be important to implement and consider while implementing countrywide self-testing. Actually, that's all from my presentation. The report of this study will be available early in December, and you will be able to download it from our website, GHRMG, and that's all from my side. Thank you, and I will be glad to answer questions at Q&A session.
Thank you very much, Tamar. And as she said, if you have questions, please do write them in the Q&A, and they will be answered at the end. And now we will move on to Momchil Bayev from Bulgaria.
Hello, everyone. Thank you for having me today. Let me just share my screen. So as you can see, I will be giving another point of view on this HIV self-testing, which we see as a new frontier in the fight against the virus in the context of an exhausted healthcare system and scarce prevention. A few words about Single Step Foundation. We serve the LGBTQI plus community, and we provide a number of various services, of course, sexual health and HIV. We also provide an online chat and toll-free hotline that is providing support to young LGBTQ plus people in regards to their sexuality or other issues related to sexuality at school or within the families. We also support a network of psychologists in 10 cities in the country, and we start two peer groups, one for young people and another one for parents of LGBT children. Jumping into the topic, I would like to start with this beautiful map of prepared by UNAIDS and WHO, showing the countries around the world that have some sort of HIV self-testing policies, either implemented or in the planning. You can see that most of the areas in the world do have some policies, but the red spots are the ones that have no policy at all. And unfortunately, Bulgaria is still one of those few countries that don't have any HIV self-testing policy in place, and we're fighting to change this. A few words about the barriers to HIV testing. Like I mentioned, self-testing was never performed in Bulgaria before Single Step Foundation introduced it. And that was for the first time in the end of 2018 when we did a pilot initiative on a national level. The stigma and discrimination of the LGBT community are the major barrier to HIV testing. We've performed a survey to examine what are the reasons for groups of risk, specifically the MSM population, and why are they not getting to testing. So it turns out that stigma and the fact that HIV testing is associated with sexuality or sex practices is already a good reason for those people to not seek testing services. 67 countries around the world criminalize same-sex activity, and that is a challenge on a global scale. Some of those perform death penalty. A few words about the discrimination against people living with HIV around the world on a broader scale. As you can see, people living with HIV often face discrimination or unequal treatment when they seek services. Some countries have specific laws that criminalize HIV non-disclosure, exposure, or transmission of the infection. 19 countries are known to have applied other criminal law provisions for similar cases. And you can also see that we still have countries who impose travel restrictions on people living with HIV, 20 of those around the world, and approximately 1 in 5 people living with HIV reported having been denied healthcare because of their HIV status. Coming back to the local context in Bulgaria, and again, prevalent stigma against LGBT people in general is very much valid for those people when they seek healthcare services, including HIV testing and treatment. In Bulgaria, HIV is institutionalized, and there is a network of 14 testing centers that are located in 2 state buildings and 17 mobile testing units. Well, none of the testing centers or the mobile units have been operating since March 2020, when the COVID-19 pandemic started. So no community testing is available anywhere in the country besides one testing center in Sofia at the checkpoint. Other than that, no community services exist. So that leads us to limited access to screening and testing services outside of the capital. And I would like to stress again that the perception that testing for HIV is for some reason associated with the person's sexuality seems to be the greatest reason that why people don't get tested or don't even seek testing services. We had the hypothesis that a large number of sexually active men who have sex with men and trans people in Bulgaria do not test for HIV due to the stigma or use condoms because of ignorance. So this is how we started our initial campaign, and we decided to introduce the self-testing with the very same brand which we saw in the example from Georgia that Tamara presented. The quick oral swab is very easy to use. It's very user-friendly. It's confidential, obviously, performed at home, allows for participants to not even having to visit a healthcare facility. We used a bottom-up approach from the community for the community. Being an LGBT organization working for that community creates the sense of trust between us and the participants. We identified the barriers, like I mentioned in the previous slide, and we came up with a solution. We used entirely digital channels to spread out the word about the possibility of distributing testing kits to the users' homes. And we partnered with the largest in the world dating app, Grindr, which is specialized for MSM, gay, bisexual, trans people who are seeking dates with other men. The user would see a message on their screen, and then they would click on a button that would take them to a short questionnaire on a website to collect data for advocacy purposes and research. And then they order the test, which we ship to their preferred address. It could be home address, or it could be an office of a courier company, and that was the choice of the users. We, of course, supported the participants with a 24/7 hotline for support. Whenever someone tested positive, they had the opportunity to get in touch with us and receive the initial support which every newly diagnosed person would need. Through that support and counseling, we of course ensure that this person would get a confirmatory testing and potentially will be linked to care, register with a clinic, start treatment, and adhere to that antiretroviral treatment. So this is on the left-hand side, you see the image of the pop-up message that we use for Grindr. On the lower hand side, right-hand side, you see the logo of the Grindr app. So this is what people saw on their screen, and although it's in Bulgarian, you get the point. It says, and the red button says order for free, and people get to that questionnaire which I mentioned. And the data that we collected is, of course, demographics, region or city where the person is based, usual condom usage, known or unknown HIV status, date of last HIV testing, attitude towards testing of HIV, other STIs, and hepatitis, and of course, testing preferences. A few lessons learned from the End HIV campaign, as we called it. HIV screening and testing services are difficult to access outside of the capital, Sofia. A large proportion of sexually active men who have sex with men at risk of HIV do not test regularly. HIV testing rate is particularly low in the trans and Roma communities, so we need more efforts there. HIV self-testing at home is the preferred screening method for MSM in Bulgaria, and digital channels are an effective route to reach the two populations. People newly diagnosed with HIV need psychological and psychosocial support on an ongoing basis. HIV self-testing sustainability is very important to us because we don't want this to be just a pilot project supported for a couple of months. And this is why we do a lot of advocacy and institutional work with the Ministry of Health to find a sustainability model for this initiative. Partnerships with international organizations such as the WHO which is providing enormous support in terms of institutional work. And just recently, WHO has posted an article about the initiative on their website, which I can show you in the end, or post a link of it in the comment section. And currently, the latest news is that WHO is creating a short documentary movie, short video showing the good example of the self-testing in Bulgaria, and that should be aired on December 1st in the context of the World AIDS Day. Another word about the context in which we work. The current National HIV/AIDS Prevention and Control program is coming to an end in 2020. So right now we're preparing the new national program that will cover the period of 2021 through 2025. So including the HIV self-testing into the programming strategic document is extremely important to us. And in the coming years, we will see a greater access to self-testing and hopefully curbing the epidemic of HIV in Bulgaria. This is it pretty much, and I'm more than happy to answer any questions if you may have, or post them in the comment section below, and I'm happy to answer them. Thank you.
Thank you very much, Momchil. We already have a question for you. I think actually the question goes out to both of you if you would like to answer. The question is from somebody who says he's been testing for HIV in Checkpoint Copenhagen for 9 years, and he knows it's still a shock for most people to get an HIV positive test. What is your consideration or your concern for people sitting alone and getting a positive answer?
I can speak from experience. Just to give you a bit of a background, we performed such self-testing initiative first in 2018. That was September, October, November, the end of the year. And we distributed 900 tests in 120 different locations around the country. 10 people came out positive, and this is the number of people who reach out to me for support and counseling. I understand that this is really a big shock for someone getting a positive result, but those users have the possibility to get in touch with the hotline even before they perform the testing. So pre-testing counseling is also available. Of course, we as professionals in doing this, we can prepare that person to do the test. And it has happened when someone needs to talk to us before they perform the tests. So we prepare them how to read the result and how to pretty much digest that new information. Yeah, pretty much I would say that it's been a positive experience. Now we perform the same initiative right now as we speak since August. And there has been a greater number of positive results, close to 15, with a smaller number of tests distributed, which means the prevalence might be getting higher. So those 15 newly diagnosed people also reached out, and they seem to be managing. Of course, everyone experiences a diagnosis differently, but the possibility of reaching out to a counselor who's a healthcare worker and or a social worker, I believe is valuable, and it's a good enough approach. Thank you.
Tamar, would you like to answer the question as well?
Yeah, sure. Of course, there always will be such population who prefers to be tested by the professional and prefer to have someone beside him or her during the testing. But we cannot lose this opportunity of reaching the type of population who otherwise would not come to the facility. So this is the great benefit of HIV self-testing, and the risk which was mentioned in the questions can be mitigated, as also mentioned by Momchil, that pre and post-test counseling information which should be provided. For instance, in our case, we provided brochures. They could call the helpline. I can also say that in case of the online service I mentioned, which is operational in Georgia, they also deliver these brochures with the self-test kits. So all this can be used as the mitigation of this risk, but we should always consider this big benefit of self-testing for reaching this under-tested population. Over.
Great. If you allow me to add another word to what's being discussed here and the concern of the person asking the question, I agree with what Tamar says, that we will always have this part of the population that prefers in-person contact and counseling in person. That is very valuable. I agree. But we have a very great number of people who are now willing to face a healthcare professional. And I can speak with numbers. We've did the survey among the MSM population and trans people in Bulgaria, covering more than 1,500 people. And there is a great majority of people preferring self-testing. And we have 1/3 of those participating in the survey that they say they never tested for HIV in their life. And this is because they will have to see a healthcare professional and they don't want to. So we need to allow this possibility to be on the table and be available for those not willing to visit a testing center. Thank you.
Maybe I would like to ask a follow-up question to that, because one thing is the risk of sitting at home and having a shock. Another thing, which you both mentioned, is actually the challenge of ensuring linkage to care for those who do test positive. What would be your main recommendations to ensure that this is done effectively?
I would, again, speak from the experience that I have in this initiative. Well, the only chance to link someone to care is if they get in touch with us. Disclosing their HIV status is their own decision. So when we send out a home test kit, the user decides whether to get back to us and reach out for help or not. So if they don't, this is, of course, their decision. They're mature citizens who can decide how to handle their health condition. Some people do prefer to find their own way within the healthcare system. They get the result positive, they find a hospital and they go register there and they're fine. Others who are shocked and have a higher level of anxiety, those are the ones who would reach out to us. And as long as we're in touch with these people, we ensure they're linked to care. All of the clients that I have been linked to care so far. Barely anyone is resistant. Of course, sometimes it's difficult, but the majority is success.
Yeah, I would also add that this can be done during the promotion of the self-test, so that we get so that they have comprehensive information about what to do after HIV self-testing. Also, this information should be provided together with the test, where they can go for confirmatory testing. Otherwise, this may be beneficiaries who come to the service organizations for testing and for some other services, and deliver this information at the facility-based visits. So all this information should be correctly provided to the beneficiaries, and even using this Grindr or other social sites, all they should promote this self-testing use together with the instructions what to do after the positive test.
Okay, thank you. Then I have another question for Tamar. The question is, have there been any studies on knowledge and awareness on self-test in the general population in Georgia, or is it only among KPs?
Yeah, it was the first study using the HIV self-test in Georgia, and it's only for the key populations. For general population, it have not done yet.
Okay, then the next question is, what if you don't identify as part of a key population group? How can you get an self-test, and how much would it cost if it's available at all?
In Georgia, it's not yet available if you are not a key population, because you cannot, well, these tests are not registered in the country. So you should identify yourself at this point as MSM, because we have only the Global Fund pilot program for MSM population, and now it is expanding to the PWID and sex worker. And we are actually planning to include the self-testing widely into the HIV national response and support the countrywide implementation. Over.
Okay, thank you. And then a question for Momchil. Why weren't self-tests available in Bulgaria before your pilot? Are there any legislative barriers to self-testing? And if so, how were you able to implement your project?
Thank you. Well, there isn't a short answer to that question. I would start from saying that the medical community in Bulgaria is relatively conservative, and it has been. There was a sense of mistrust of the self-tests, and the medical community used to believe that only blood tests could be reliable, and even the rapid blood tests with a drop of blood were hard to swallow in the beginning when they first arrived. So any new thing is difficult for institutions to accept or to trust. So self-testing, especially done with an oral swab, is seen as something new, something could be exotic if you like, and that's why institutions are not very much open in the beginning, but now we see change in that attitude and that acceptance. So lately, I've been seeing healthcare institutions in Bulgaria, particularly the Ministry of Health, becoming more open to the idea of self-testing. And the second part of the question, were there any legislative barriers to self-testing? Well, there is a piece of legislation that regulates HIV testing in general. So self-testing has never ever been regulated. It's never been part of the legislation. So it's neither allowed nor forbidden. The legislation only speaks of the HIV testing that's performed with blood. So we distributed oral swab, which is non-interventional method of screening. So when there's no blood involved, we didn't have any obstacles to perform it, as long as we, of course, provide support and counseling to the participants.
Then there is a follow-up question about whether you're actually suggesting an open hotline that's open 24/7 if you do introduce self-testing.
Well, right now, it pretty much operates 24/7 indeed, because we work on a smaller scale. Although we cover the whole country, we don't have an enormous number of participants calling for counseling. So far, since August, we've distributed about 500 self-testing kits, and we've had about 15 positive results. This is not very much, although we get a lot of other questions on that hotline, concerns about sexual practices, high or low risk, anything related to sexual health. And yes, 24/7 hotline is great, but it depends on the demand. Usually when people perform a self-test at home, they tend to do it in the evening. During the day, everyone's busy with school, work, their everyday life. They don't think of HIV when they go to work. And when they get home in the evening, some people stay alone and they start worrying about things. And this is when they would perform the test most likely. And in the evenings, we get most calls or emails, whatever channel people prefer to use, because the hotline is not the only option. And that's why it's very important for the hotline to operate in the evening hours, because this is when people have elevated anxiety as well. This is when they feel alone and lonely, and support is very important at night.
Okay, thank you. I have a final question, and the question is for Tamar. The question is, are there any plans for maintaining self-testing after the study completes in Georgia?
Yes, as I mentioned, we're expanding this pilot project to PWID and MSM. Otherwise, within the project, we plan to have promotion campaigns for promoting the self-test for key populations. And the nearest plans just include the expansion of the pilot project under the Global Fund project.
Okay, thank you very much. So if there are no more questions at the moment, we will include, sorry, there's a question. Just came in last minute. The question is here, a question for both of you. The person is saying, thank you very much for your presentations. My question is about how you can secure anonymity of the participant that wants to test. Our experience is that anonymity and discretion is essential to reach out to risk populations.
Well, complete anonymity is difficult to maintain, especially when someone orders test online that has to be shipped to their home. So it is impossible to do this without having person's name, phone number, and address. So this is not entirely anonymous, but it's definitely confidential. We try to pretty much ensure that the data of these people is very much secure. We comply with the national legislation on data protection and also the GDPR of the European Union. And we have a very detailed consent form for the users who order the test. And we explain we do collect data, but this data is stored and it's used for certain purposes only within the framework of this testing initiative. We don't store the data outside the scope of the initiative, and we don't disclose it to third parties for whatever reason. And the good part is that only one person in the office has access to this data, and this is very important for people to know that their data would not be spread out.
Yeah, I would also add that within this study, of course, it was not anonymous because we asked for the phone number or the follow-up questionnaire, but they were non-identifiable participants. We didn't ask their names. We used the unique codes, and the same unique codes are used by the pilot project. So the client who wants to order online has to register himself by the unique code. But again, he has to indicate the phone number in case the courier wants to make to ask something about the address. Yeah, full anonymity cannot be ensured. Otherwise, if it's sold in the pharmacies, so the participant can just or someone from general population can just buy it in the pharmacy and do alone, and it will be anonymous then.
If you allow me to add a few words to that question, I believe it's very important for our community that they know we're a community organization. So we are also part of that community. It's not like going to an office of the Ministry of Health, disclosing your identity and seeking HIV testing and potentially getting a positive result. That would be one thing. But when you reach out to a community organization that is pretty much living and breathing that work and understands the specifics of that community, I believe that that is a very important component of the trust that we have with our communities.
Okay, thank you very much, both of you. Of course, if anybody has any additional questions, you'll be most welcome to send them to us afterwards to the European Testing Week Secretariat, and we'll make sure to forward them to the presenters. And finally, I'd like to remind you, please, to fill out the short evaluation survey that will be sent to you. And like I said, the recording of the webinar will also be sent out to everybody who registered for the webinar on this address. So I think we've covered everything. Thank you very much, everyone, for joining.
Thank you.
Thank you.